much for being here with you. It's my pleasure to update you on CRS development for CBT101. So, as you probably know, CRS is a spin-off from the CEA, which is an academic organization in France. And CEA has been working with Alois Mabonzo on CBT101 for years before we were created. We started in 2013, but maybe a little bit earlier than that. 2019, we created Brain Therapeutics with my colleague Henri Benesch, who is fully associated to CRS, and Alois Mabonzo, who is present, who is staying in his lab. We did a lot of experiments that we already presented here at this symposium with Alois. In 2021, we did an experiment which is important in non-human primates, showing that our product was able to deliver creatine within neurons. And in 2022, we were able to stabilize our product. And this was also very important because by stabilizing it, we were able to make a drug that could one day be in patients. 2023, we developed our formulation to being able to have what we call a good manufacturing practice formulation, meaning that it answers the regulatory rules of drugs. At the same time, we also conducted some non-regulatory toxicology studies, which is also very important because we showed that our drug was not toxic for patients. 2024, so 2023 and 2024, we were conducting the IND enabling studies, more the IMPD enabling studies actually, because we are focusing on Europe. And so we are now moving on the clinical stage. So just to remind everybody, our solutions that we propose appears simple, but it's truly a lot of it's full of innovation and it's not so easy. So CBT101 is a drug that is a nasal spray. We spray this drug in the nasal cavity, obviously. Within the nasal cavity, the drug has the ability to enter the olfactory and trigeminal neurons. Within these neurons, it migrates toward their origin, which is the olfactory bulb, and the trigeminal core. Trigeminal core and olfactory bulb are within the brain. So we completely bypass the blood-brain barrier. While in this origin of these neurons, it diffuses from one neuron to the other to all brain areas. And we were able to show that. How does it diffuse? We don't really know. However, CBT101, as well as creatine, is everywhere in the brain. So our assumption and our understanding of the product is that within each neuron, CBT101 releases creatine, and creatine is well known for its metabolic effect. It decreases mitochondrial stress, decreases inflammation. It is a direct antioxidant. It's anti-apoptotic, anti-excitotoxic, but mostly it provides phosphate for the formation of ATP. So it's buffering the energy within the cell. And this is probably what is mostly important for CTD, but for also some other neuro diseases as well. So I showed this data last year, and I was not alone. Alois Mabonzo showed that also, and our friend Nicolas Tournier showed some results in Paris during the extraordinary symposium last year. To summarize what we have is that CBT101 is able to deliver creatine into neurons. We proved it in CTD mice. We proved it also in non-human primate, which is very important because non-human primates are really closer to us than the mice. Our product in the blood is metabolized in a matter of seconds in creatinine, and we know that creatinine is not useful for the brain. In non-human primate, our product that was labelized with stable isotope was able to be detected in the neurons, mainly in the neurons, not in the glia, not in the endothelium, after 30 days of treatment. And the amount that we detected was 50% of the total amount of creatine, meaning that in 30 days we were able to really give a certain amount of creatine within the neurons and a certain amount that probably can have an effect. In SL6, A8 mice, cow mice, what we showed also was that our product increased the brain plasticity. We showed it through synaptic biomarker increase, PSD95, CREB, and BDNF. We showed also, and it was demonstrated last year by Nicolas Tournier, that the brain metabolism was increased thanks to an FDG test with PET scan. And lastly, and thanks Matthew to have shown the graph a little bit earlier, we showed that the NOR test was improved, so the novel object recognition test was increased in SLC6A8 cow mice, meaning that the cognition of those mice was improved. So we do have a product that is active biologically, active in terms of metabolism, and active ultimately in terms of clinical symptoms. What we assume is that it's important to deliver this product every day. The amount of creatine that is delivered is probably not a lot. However, it's sufficient to change things. So it will be a chronic treatment for life. And it will deliver a small amount of creatine, reaching the neurons through 1 or 2 or maybe 3 daily administration. The movie is my 2 daughters to show you that it is very easy. So the youngest one is 6 years old, and the oldest one is 10 years old. It's really just a nasal spray. Very easy in my daughter, there are no problem. In younger kids, problem or not, we all know that nasal spray can be difficult. But it's just a nasal spray. That's the same movie. It was difficult to make them not laugh. So, since last year, what did we conduct? I said it a little bit at the beginning, but we did a short-term tox study. We did safety studies according to regulatory rules, meaning that during 15 days, animals in a regulatory environment received the product. And at the end, they were sacrificed. There was no problem in the brain, no problem in any other organs as well. We also developed a processus to produce industrialize a drug. This is the GMP processus, and we manufacture the clinical batch for phase 1. And we also started, and we almost finished, wrote the investigation brochure, which is essential to file the IMPD and then the IND, meaning the investigational medicine product dossier or the investigational new drug dossier for the FDA. This is our development plan, and I'm putting dates, but these dates will really depend on our funding. And today we need to find some money. We are raising $10 million, 10 million euros to pursue our development. The gray bar show what we have done. We will file the dossier end of July. Hopefully we'll get an approval from the regulatory authorities, and 2025 will be the conduction of a phase 1 in healthy volunteer, while starting by healthy volunteer because we have a new drug. We are delivering the new drug directly into the brain through neurons. So, and it will be important to have the assessment of people being able to say, I have headache, I have a problem, than going straight to patient who won't be able to say, well, I'm feeling not well. So that's why we want to do that. And truly, all of our advisors said it would be much faster to do a phase 1 in healthy volunteers than to try to do a phase 1 in patient directly. At the same time, we need to conduct what we call a long-term toxicology, including juvenile animals. As I said, it will be a chronic treatment. So what we want to do is 3 to 6 months long-term toxicology first, before, it's not what we want, it is required by the regulatory rules. We need to conduct this study to be able to give the drug to patients during our phase 2-3, starting end of 2025, beginning of 2026. Again, I cannot engage Ceres and the team on this date because it really depends on funding, when we find it, and then the success, obviously, of 2025 studies. 2025 studies will be conducted in France, mainly. Phase 1 will be conducted in the French Alps, actually, where there is a great facility that knows very well neurological diseases. And the long-term toxicology study will be conducted also close to Paris in a facility where they have a lot of habitude to conduct that kind of study. Regarding phase 2-3, the exact protocol is still under development. I preempt the future question about sex. Will it be only male? Will it be female or male patient? The answer will be probably depends also on funding. With more funding, we can do more patients, and we can include both sex, and we know that there are differences between both sex. But as a matter of fact, regarding what we propose, delivering creatine within neurons, sex difference should not be a problem for our study. Will it be a monocentric study or a multicentric study? Monocentric in a rare disease is always very difficult. Orkuri will talk a little bit later, and she demonstrated that she was able to get a lot of patients in an observational study. So this might be feasible. And again, depending on funding, having a multicentric study, Europe, US, Canada would be the best, but we know that it's very expensive. And it's probably needing more than 10 million euros to do that. So lastly, I would like to thank my awesome team. Henri Benesch, who is not here, I'm working with him every day, is totally dedicated to CBT101 and CTD. Alois Mabonzo, who is here, also you know him, you have been knowing him for years now. He's totally dedicated to this disease. And we are working with Andreas Schulze. He's not here today. And well, thanks a lot to him because he is helping a lot. Aurore is not on the slide, but she could be on the slide because she has been helping us a lot as well. And thanks to Carol and the Extraordinaire in France, and obviously to Heidi and the ICD team. If you have any question, I can answer, but I cannot promise anything regarding dates of studies.
Thank you very much for your presentation. Very nice and very promising. And any question from the group? Oh, there is already one here.
Hi, thank you so much. I know that a lot of us in the community were anticipating this and have been anticipating this, so I appreciate you coming all the way from Paris. I guess my question would be if and when you plan to file for orphan drug designation along the way.
It's already done. It has been done in 2021.
Okay.
Europe and USA.
Excellent. Or like fast track designation from the FDA.
That will be done after IND for
okay.
fast track designation.
Wonderful. Okay, thank you.
Do you expect that this drug might be available to GAMT patients as well, possibly?
Well, when we filed for orphan drug designation to the EMA, they called us on the phone telling, well, give us some data regarding epidemiology of GAMT and AGAT, because we want to grant you orphan drug designation for those two diseases as well as CTD. So for this expert, the answer is yes. And actually, as I said, we are delivering creatine to neurons. So it should work for GAMT and AGAT. And it's probably much more easier than getting 10 grams or 20 grams a day of creatine.
Right. Thank you.
Do you expect this drug to help with the seizures and the developmental delays?
That's a very good question. In SLC6A8 mice, we truly have a tremendous result. The mice in the cage, which is not moving at the beginning, after 30 days of treatment, is moving everywhere. She's much more curious than it was before. So we expect to have really good results. based on what has been said previously, probably the younger we treat, the better the result. Younger being, we don't know, before 7, before 5, we don't know. During teenagers and for adult patients, giving creatine will probably have some benefit, maybe on seizure, maybe on weird motion, autism syndrome, we don't know, and nobody knows.
Hi. What outcome measures will you be using? Will it be the same as the core outcome set or something else?
Sorry, I don't get your question.
What outcome measures will you be using?
For CTD, outcome measure. There are 3 pillars: the seizure, the autism syndrome, and the cognition defect. Seizure, I mean, there's seizure or there is not seizure. It's quite easy to measure, I would say. And it's not so easy because you have some partial seizure or some patient having seizure and nobody knows they have seizure. Autism syndrome, there's some tests to measure social behavior. And for cognition, I will let Aurore do her presentation because she has some really good things to share with all of us. I think there's an article that has been published a few years ago from someone called Brun, B-R-U-U-N, and she was describing a score in her article. And building a score, composite score, based on what she said is probably a good way to assessing change in the patient. We did some protocol assistance with the EMA, and the answer were it will be probably difficult to show something in all these heterogeneous patients, so measure as many as possible outcome measurement, and we will sort out what should be taken into account for future approval. That was exactly the answer, so helping.
Hi, I saw that you already went to ANSM and EMA. Do you guys plan on going also to the FDA? And if you receive very different feedback from the agencies, do you plan on, focusing on one of them, or would you be possible to go to parallel, advice, so that they're on the same page?
Well, they are never on the same page. I mean, if US people were on the same page as European people, it would be big news. First of all, no, parallel process between US and Europe. Some people say it's very great. Some others, advisors, say, well, don't do it. It's better to have advice from one agency and advice from the other. We plan to go both. We'll not do it at the same time. So there will be, different steps in our development. And we will need to take into consideration the different answers, obviously. If we get great success with our drugs, whether it is in Europe or in the US, I think the other agency will follow. Again, CTD, GAMT, AGAT, there is no treatment today. And that will be probably the time also where lobbying with you, with Extraordinaire, will be very important with the agencies.
I hope this question makes sense. Does it matter if the kiddo is not able to sniff in? Like, is the propulsion of the spray enough to get it where it needs to go? So, like, for example, Levi will let us, squirt something up his nose, but he doesn't really, sniff it in.
Well, so it's a nasal spray, meaning that with your finger, you have seen my daughter, you're just pushing on something, and the spray is getting out. We are spraying 70 microliter in the nose, which is not a lot, and we have tested on ourselves. It doesn't drop in the front or in the back of the nose. So, I mean, it's probably not a problem that your son is not sneezing. What is probably important, however, is that he needs to have a clean nose before receiving the treatment. So someone who has a running nose, he may need to be clean before with some physiological serum first, and then 5 minutes later you do the puff. But truly the puff, there is not this sensation of having water going out in the back of the nose or in the front of the nose.
I have a question myself, and the question is, what type of dose can you deliver intranasally with each administration?
It's a funny drug because we have a fixed dose, which is 2.3 milligram per puff of CBT101. So this is what we deliver. However, what goes to the brain, it's exactly the same answer as an antidepressant that you take by the mouth. It goes into your stomach, it goes into your blood, and then nobody measures it in the brain. Because nobody cannot measure something in the brain today. We may measure something in the CSF, we may measure something in the blood, but it will be just a cinetic. We cannot do a cinetic in 50, 60 non-human primate. But it's a question that we get from venture capital firms saying, well, what is the amount of drug reaching the brain? And actually, we don't really know, which is difficult.
Thank you. Any other question? Thank you very much for the presentation. Thank you.